Thank you, sir, for the kind introduction, and I thank Dr. GVK, sir, and the 3D Con team and Lily for having me here today to talk on decoding Mounjaro's superior results versus Semaglutide. We heard a lot about how this molecule has evolved in terms of its place in the management of type 2 diabetes and obesity. So we will now look at a comparison with the GLP-1 receptor agonist Semaglutide and as to how we can place this molecule in our clinical practice. So I've been contacted by Lily for this talk. The slides have been provided by the company, but the thoughts and the interpretation of the data is my own. And most of this data are already published, and you will be able to find it in any scientific platform. So GIP and GLP-1, the wonder incretin hormones, they are not very redundant hormones, they are very, very potent hormones. Now, GIP was discovered almost half a century ago, but then it was considered to be less useful in terms of diabetes management, and historically, GLP-1 has been the therapeutic target with regards to diabetes management. But thankfully, the paradigm has changed now. We have understood so much more about GIP, and that is why GIP has also been included in the diabetes management as part of the tirzepatide. Now, GIP and GLP-1, though they are broadly put under the incretin hormones, they have very similar central action. So their action at the level of hypothalamus at the arcuate nucleus is to reduce the food intake, as you can see here, and also improve satiety. But when it comes to nausea, which is primarily the action of GLP-1, because of its direct action on the chemoreceptor trigger zone, which is at the fourth ventricle, it causes more of nausea, whereas in contrast, GIP doesn't cause that much of nausea, rather has some amount of antiemetic effect. And that is the reason why when you have a combined GIP and GLP, we find patients not much complaining about nausea and vomiting compared to GLP-1 receptor agonists alone. Now, when it comes to pancreas, though both these increase insulin secretion, the predominant action of GLP-1 is to completely suppress glucagon and have its suppressive action on the alpha cells. Whereas when it comes to GIP, it modulates the glucagon effect depending on the blood glucose. So in people who have normoglycemia or hyperglycemia, it tends to suppress the glucagon. But when somebody has hypoglycemia or a lowish glucose, it tends to push up the glucagon. So that is a differential action of GIP in terms of glucagon. Now, when you come to the gastric action, you will see that the predominant action on the GIT is by the GLP-1, whereas a predominant action on the adipocytes and the adipose tissue is by the GIP. Now, this is important because we have two similar hormones but have differential effects on every single organ, and that makes sense to bring these two molecules together because we know and we have learned that we have to address multiple pathophysiological defects while we manage patients with type 2 diabetes and obesity. Now, this is something interesting. Why do we have to bring in a GIP? Why not just go away with GLP-1 receptor agonism? Now, GIP, as I already mentioned, has a differential role to play depending on whether an individual is in a fed state or in a fasting state. Now, what happens in fed state is that the moment the glucose starts going up, GIP starts increasing the insulin secretion, brings down the postprandial glucose, and more importantly, enhances the lipid clearance. And simultaneously, it also increases the free fatty acid uptake and the triacyl glycerol hydrolysis. So basically, this promotes lipid storage. So when in fed state, it increases the lipid clearance, promotes lipid storage, and that is how it really enhances not just glucose control, but also the lipid control. Now, in the fasting state, it stimulates the glucagon secretion, as I already mentioned, and more importantly, it stimulates lipolysis, leading to a significant release in free fatty acid and glycerol, just to help these patients maintain the glucose and the lipid level. Now, this is very important to know because GIP acts as a metabolic switch. So, depending on the glucose levels, it tends to stimulate or inhibit the lipid release and the lipid storage. Now, what happens when you have a molecule like tirzepatide, which is Mounjaro, with GIP and GLP-1 receptor agonism? Now, the tirzepatide is nothing but the GIP molecule, which has been modified enough to have a predominant GIP receptor agonism and to some extent a GLP-1 receptor agonism. So it has more of GIP than GLP-1 receptor agonism. And that is the reason why you will see in this graph that the purple line, which is the tirzepatide, is in very synchronous activation of CAMP, as it exactly mimics a GIP-1 receptor agonist. Whereas onto the right side you will see that the tirzepatide is slightly different or slightly weaker compared to the native GLP-1. So the tirzepatide has a very similar predominant or dominant GIP action compared to the GLP-1 receptor action, and this is what we call it as biased agonism. So we are trying to make the most out of GIP and also having a GLP-1 effect in order to give you the overall benefit that we are going to discuss. Now, what happens when you really have a GLP-1 receptor agonist versus when you have a GIP and GLP-1 receptor agonism? Now, this is a mechanistic study where they looked at mouse models with knocked off GIP receptors as well as GLP receptors. Now, in this left-hand panel, you can see that in mouse where the GIP receptors were knocked off, you can see that the tirzepatide did show an effective glucose reduction. You can see the glucose levels in the purple continuous line showing a reduction in the glucose, strongly pointing towards a potent GLP-1 action. And you can see the broken line one, which is the semaglutide. So when there was a GIP receptor knockout, you will find that both tirzepatide and semaglutide did improve the blood glucose. Whereas in GLP-1 receptor knockout models, you can see the broken lines up there. So semaglutide did not provide glucose control or glucose reduction, whereas tirzepatide still did show a glucose reduction. So this is the reason why when you have these kind of a different biological action, or this helps to provide a dual agonism and gives you a more meaningful biological incretin-like effect. So the Mounjaro tirzepatide is the first and only approved dual agonist molecule, the GIP and GLP-1 receptor agonism, which acts predominantly at the GIP receptor because of its similarity to the GIP molecule, and also works at the level of GLP-1 receptor. Now let's look at the differences. Now, how do we really compare the dual agonist, which is tirzepatide GIP GLP-1 receptor agonism, versus semaglutide, which is the GLP-1 receptor agonist? So we are going to look at three things. One is glycemic control, two, we'll look at weight reduction, and three, we will look at the metabolic parameters to see how each of these molecules fare. Now, when we talk about glycemic efficacy of a molecule, we consider these three entities as the pillars to assess glycemic control. One, the beta cell function, two, insulin sensitivity, and three, the glucagon concentration. So we'll first look at the beta cell function. Now, this is the hyperglycemic clamp, where volunteers are given glucose infusion to create hyperglycemia to see how these two molecules work. Now, the left-hand panel shows the first phase insulin response to the glucose infusion. Now, if you see, compared to the placebo, semaglutide did show an increase in the first phase insulin response, but the purple bar, which is depicted by tirzepatide, shows a much higher and superior first phase insulin secretion following the glucose infusion. Now, this tells us that there is an immediate response or immediate insulin secretion following the glucose in the clamp. Now, when you look at the second phase insulin response, again tirzepatide scores over semaglutide in terms of not just immediate insulin release, but also sustained insulin release. So this hyperglycemic clamp just tells us that it's not just about reducing the glucose or increasing the insulin that happens with tirzepatide and compared to semaglutide, but it's more importantly the improved beta cell function or the improved beta cell responsiveness to the glucose that we are seeing. Now, the second entity is to look at the insulin resistance. We all talk about insulin resistance. We know that patients with type 2 diabetes, and especially when they have overweight or obesity, have an associated insulin resistance, which we have to always target. Now, the hyperinsulinemic euglycemic clamp is the gold standard to actually study the insulin sensitivity. Now what you see here is the broken lines are showing the baseline glucose infusion rate when somebody is having a euglycemia or a blood glucose control. Now what happens when these patients are given semaglutide? So when the grey solid line shows patients who are given 1 milligram of semaglutide, you can see that the glucose infusion rate is slightly higher, which means that when somebody's blood glucose is maintained, this molecule works really well in terms of improving the insulin resistance. So therefore the requirement of glucose is higher to maintain the blood glucose. Now if you look at tirzepatide, the tirzepatide glucose infusion rate was much higher compared to semaglutide. So what happened to the numerical improvement in terms of insulin sensitivity? Now compared to the semaglutide, which increased the insulin sensitivity by 35%, tirzepatide increased the insulin sensitivity by 63%, almost double that of semaglutide. So that kind of tells us that it does improve insulin sensitivity in patients who are maintained in the euglycemic clamp, which could be part of type 2 diabetes as well as for obesity. Now this benefit of insulin resistance is directly because of the weight loss that we see with this molecule, and also because of the enhanced GIP action, which is directly on the adipose tissue, which we also discussed. Now the third thing is about the glucagon concentration. Now as I already mentioned, that glucagon is something which we always have been confused with. Initially we thought that glucagon was bad. We were looking at glucagon antagonism to improve the glucose control. But now we know that even with the triple agonist that we are yet to have, we have the glucagon agonism also helping and probably working in synergism with the GIP and GLP-1 agonism to help patients with diabetes and obesity. Now in this particular study, what they showed was whenever there was hyperglycemia, you can see compared to the baseline, the tirzepatide levels were much lower, which means that when the glucagon levels were much lower with tirzepatide. So when there was hyperglycemia, the glucagon level went down with tirzepatide, and when there was hypoglycemia, the glucagon levels were as similar to the placebo in patients who were on tirzepatide. So that means that we are able to preserve the physiological glucagon regulation when patients are on tirzepatide, so we don't have to worry about hypoglycemia in those patients. Now let's look at the weight reduction. So in weight reduction, we'll be looking at the appetite and the hunger effect of tirzepatide versus semaglutide. We will look at the quality of weight loss, because it's not just about the quantity of weight loss in terms of how many percentage of body weight that the person has lost, but it's more importantly which fat did he lose and what else did he lose. And thirdly, we will look at the hedonic behavior, where we talk about the craving reduction, the food reward system that has also been manipulated by this class of drugs. The first study shows that when people were asked to eat on their own, like freely, how much ever they wanted to eat, compared to placebo as shown in the broken lines, you can see both the semaglutide and patients who were on tirzepatide did show a significantly lesser calorie intake, even when patients were asked to eat on their own and freely. Now to give a numerical value, you can see that the calorie intake was significantly lesser with tirzepatide when compared to semaglutide. And when we look at the quality of weight loss, because it's not just about how much numerically that they have lost, what was the difference that was seen in the weighing scale, it's about what did they actually lose. Now with any weight loss which is above 5 to 10% of total body weight, there tends to be a lean muscle mass loss as well, and that goes whether you are having a lifestyle intervention, drug, bariatric surgery, whatever it may be. Whenever there is more than 5 to 10% of body weight loss, there is going to be a lean muscle mass loss. So our intention is to enhance more of fat mass loss and reduce the fat-free mass loss or the lean muscle mass loss. So when you look at patients who are on tirzepatide, the fat mass loss was much more pronounced when compared to fat-free muscle loss, and you can see that the overall weight loss was much more with tirzepatide at the end of 28 weeks compared to semaglutide. Now to give a value to it, you can see compared to the total lean muscle mass that was lost, there was almost 3 times the total fat mass loss in patients who were on tirzepatide, and 4 times more visceral fat mass loss in patients who were on tirzepatide. So this tells us that it's not just about the overall numerical reduction that we talk about in terms of like coming down from 130 to 120 kg, 100 kg, 80 kg. It's not just about that. It's about losing the visceral fat, which is the predominant risk factor for insulin resistance, cardiovascular risk, and even the MSLD and all that. So it's more of a visceral fat loss that these patients have experienced and not just mere numerical loss. Now, the third important category is cravings. Now, we talk about the homeostatic regulation and as well as hedonic regulation. So, homeostatic regulation is when people are not eaten for a long time, they are kind of starving, they have hunger, the cues are going into the hypothalamus, and that triggers the appetite, and some people eat. Now, the hedonic eating is kind of a craving and a pleasure eating. So, if they're happy, they eat. If they're sad, they eat. If they're angry, they eat. Just because somebody offers, they eat. So all these hedonic eating is also taken care of by this class of molecule. Now, if you see, regardless of whatever be the food that was offered to them, they did have reduced cravings and reduced intake when patients were on tirzepatide, as shown in the purple bar, compared to semaglutide. Now, the last slide is on the metabolic benefits with regards to the cardiovascular benefit. Now, though we talk so much about the glycemic control and the weight loss with this molecule, unless it translates into a cardiovascular risk reduction, it's not going to make any clinical sense to help our patients to be on this molecule. So, in the SURMOUNT-1 trial, tirzepatide showed a significant blood pressure reduction, both systolic and diastolic blood pressure reduction. Though it may not be a significant blood pressure reduction like what we would expect from an antihypertensive, it's of course not a substitute for an antihypertensive, but it does give a meaningful blood pressure reduction, and more importantly, it also takes care of the central obesity, where it also gives a significant waist circumference reduction, again pointing towards the cardiovascular benefit that this molecule can offer. Now, the lipid profile, again, in the SURMOUNT trial, at the end of 72 weeks of tirzepatide in patients who were having overweight or obesity, you can see there was a predominant reduction in the triglycerides as well as VLDL cholesterol, which goes hand in hand, and you can see a marked increase in the HDL cholesterol. Now, this is again primarily due to the weight loss as well as the direct effect of GIP on the adipose tissue, and that is what makes this dual agonist having an edge over the single agonist. So to summarize my talk, Mounjaro tirzepatide is a dual agonist. We call it unimolecular dual agonism, which means it is just a single molecule that has a dual agonism with GIP and GLP-1 receptors, predominantly with GIP and to some extent with GLP, and therefore it has a central action to reduce the appetite, improve the hunger, improve the satiety, and reduce the hunger. Second thing is it deals with the homeostatic regulation and hedonic regulation. Now, when it comes to glycemic control, it does bring down the insulin resistance, improves beta cell function, and more importantly, it also allows the physiological play of glucagon so that there is no risk of hypoglycemia, and we are able to achieve an A1C close to 5.7% as was shared by Dr. Sheila without the fear of hypoglycemia. And last but not the least, it's not just about the quantitative blood glucose reduction or a quantitative weight reduction, it's about the qualitative glucose and weight loss that adds on to the superiority of this class of dual agonism over the other available conventional drugs. So thank you very much, and I will stop here.